This is our presentation for NURS620, Culture and Health, Critical Perspectives, Critical Forum, Gender, created by Nicole, Marcia, Carol, and Stephanie. Land Acknowledgement. We acknowledge that today we are gathered on the unceded territories of many First Nations. We recognize and honor their enduring connection to this land, its waters, and all that call it home. We are committed to fostering respectful relationships and supporting the ongoing work towards reconciliation and healing. As we come together in this space, let us reflect on the rich cultural heritage and history of the Indigenous peoples who have cared for this land for generations.
Our learning objectives are: describe the difference between gender and biological sex, identify barriers patients of diverse genders have to equitable care in the current healthcare context, explore how intersectionality impacts healthcare access, outcomes, and experiences in Canada, identify frameworks that can be used to improve current gender inequities in healthcare, and explain strategies and interventions on how to adjust gender inequities and barriers and ensure their sustainability. To start this discussion, we're going to go over a couple of important definitions: sex and gender. Often in healthcare, we discuss these as interchangeable terms, however, they are not. Sex is a biological term, whereas gender is a socially constructed idea. Sex has to do with the physiological features and functions of one's body, whereas gender encompasses one's perception of self, societal norms, including roles, behaviors, and relationships. The concepts of gender can change over time, whereas sex is less fluid. Gender bias has existed in healthcare for a long time. The biomedical model has focused on the white male patient as the ideal, which perpetuated bias against women and girls. Medical education continued to teach this hierarchical construct, causing a continued bias in practice and research. Another way the biomedical model demonstrated bias is it believed that when a person's identified gender deviated from their sex at birth, this was abnormal and negative. Now that the definition of gender has evolved from physiological sex to a socially constructed idea, care is focused on how to alleviate the distress the patient feels. However, medicine is still catching up. Palmer and Clegg note there are many reasons why there's a gender bias in healthcare, stating there are no standard scientific definitions of gender and there are no clear-cut ways to factor gender into healthcare, which further perpetuates this issue. This is why bias exists on a personal level, provider level, organizational level, and systems level.
Language in healthcare interactions should be culturally sensitive and respectful of terms that transgendered and gender diverse (TGD) groups would use. Additionally, this language is important in the context of health research to remain true to the TGD community. Here are some definitions and appropriate language.
What is intersectionality? Coined by Kimberly Crenshaw in 1989, intersectionality is described as a lens to see where different forms of power intersect and overlap. For example, race, gender, class, and 2S LGBTQIA+ identities. Crenshaw also cautions readers against two common misuses. One, treating intersectionality as everything and anything, which risks interpreting it vaguely, and two, using complexity or the idea that it's complicated as an excuse for our inaction. The Wheel of Privilege and Power is a visual framework used to illustrate how different aspects of a person's identity can contribute to privilege or marginalization in society. When viewed through an intersectional lens, especially in relation to gender, it helps reveal how overlapping social categories like race, sexuality, class, and ability influence people's experiences of power and inequality. The wheel is usually organized in concentric circles, the closest to the center being the most privileged positions, and the outer rings being the least privileged position. Intersectionality in the Canadian context. Weerasinghe et al. 2023 suggests that intersectionality encourages looking upstream at colonial history, racism, socioeconomic status, location, culture, and identity and other axes that interact. They also see intersectionality as enabling more holistic, structural, systemic thinking. It's not just about acknowledging that someone has multiple identities, but about understanding how systems of power shape how those identities are experienced.
Health equity for women. Human computer interaction and women's health research is increasing and resists the healthcare practices that favor the cisgender male body. This research is critical, feminist, and liberatory in nature, and hopeful for those who are marginalized in health research. An example of where this research is relevant and necessary is in the context of domestic violence. From a biomedical perspective, a woman is a patient who needs medical attention and care. However, from a social perspective, action in society surrounding violence against women and empowerment is the focus.
Why does intersectionality matter? Research tends to ignore how intersecting social forces, such as colonialism, racism, and poverty, limit options for Indigenous youth. Intersectionality is used to critique that narrow framing. Healthcare services often assume a one size fits all model, which fails to address unique needs at intersecting identity points, like Indigenous youth in cities versus rural areas, or Indigenous girls that experience gender based violence. The Reclaiming Power and Place report takes a strong intersection and gender based approach to understanding violence against Indigenous women, girls, and 2S LGBTQIA people in Canada. It recognizes this violence is not just gender based, but also rooted in colonialism, racism, poverty, and systemic inequality. The report also highlights how multiple identities like Indigenous identity, gender, sexual orientation and geography, socioeconomic status, and historical trauma interact to increase someone's vulnerability. By including the voices and experiences of 2S LGBTQIA people, the report expands traditional gender frameworks and challenges mainstream approaches to justice and safety.
In this section, I will discuss strategies between two complementary frameworks, GIEH, which outlines the multi-level determinants of gender inequality in health, and a gender binary health system framework, which reveals how binary design choices in policy, data, and care pathways lead to gaps in access and quality. I will further develop these concepts into actionable steps that we can implement and evaluate. For the first framework, we'll be discussing the GIEH framework created by Kalidin et al. 2025. This serves as a comprehensive multi-level guide to understanding the factors contributing to gender disparities in health and identifying potential intervention points. For the overview of this framework, it has the micro context, which encompasses norms, policies, and power dynamics. Health system encompasses aspects such as governance, workforce, financing, and data management. For community and household, that focuses on social support, caregiving, and available resources. And lastly, for individual context, that includes knowledge, agency, and exposure. This framework establishes clear connections between determinants and outcomes, which include morbidity, mortality, health related quality of life, and life expectancy. By doing so, it enables teams to pinpoint barriers, devise strategies across various levels, and assess impact over time. In summary, the GIEH framework was designed to translate causal pathways into actionable insights for both policy and practice. Second, we'll be looking at the binary health system framework, which was developed by Lovejoy et al. 2023. This framework views the health system as a contributor to inequity by embedding male and female binaries into policies, data fields, protocol, spaces, workforce training, and financing. These decisions lead to erasure, misclassification, gatekeeping, and privacy risk, which perpetuate stigma and cause discrepancies in care pathways. Its aim is pragmatic, which is to uncover the structural factors that contribute to these issues and to guide a redesign that embraces the following: gender expansive policies, inclusive electronic health record fields and datasets, affirming environments and signage, clear clinical pathways, and funded training. This approach seeks to enhance both access and quality of care. To effectively address the domains outlined in the GBHS framework, we must consider implementing the following actions. 1. Revise policies and governance. 2. Ensure data and IT systems are inclusive and private. 3. Redesign clinical environments and pathways. 4. Invest in workforce training. And 5. Tackle financing and logistical barriers. To ensure that these actions are executed at the system, community, and individual levels, this is where the GIEH framework comes into play and to utilize its concepts. So, how do we ensure that the implementation process is done correctly and that sustainable changes are made? Well, we must execute the plan throughout all levels of the GIEH framework, paying careful attention to both operational elements and resulting outcomes. We must monitor the following: policy adoption, electronic health record field activities, and training completions. We must measure and analyze metrics associated with access, quality, and user experience. Additionally, keep track of key outcomes such as morbidity, mortality, health related quality of life, and life expectancy. And the most important of all, involve patients to refine and improve the next iteration based on their valuable insights and feedback.
Stigma and vulnerabilities for transgender and gender diverse people. Health equity for TGD people involves understanding that they have the same healthcare needs as cisgender people. However, cis-normative protocols and heterosexism are pervasive in healthcare, leading to inequities when a transgender woman might need their prostate checked, or a transgender man may require screening for cervical cancer. Structural and systemic barriers are also in place for this group. Indigenous people and people of color, as minority groups in the TGD community, face power differentials which impact their healthcare encounters and experiences. A healthcare interaction with a TGD person might be challenging for two reasons: either the patient's discomfort with disclosure of their gender identity information, or healthcare providers might not know how to ask for this. Sharing gender identity data with healthcare staff, family, and others can increase the risk for harm for TGD people. Thus, health information communication technologies can help with the private disclosure of gender identity data. The World Professional Association for Transgender Health Electronic Medical Record Working Group is a great example of using clinical tools to address inequities. It assists with digital representation of transgender and gender diverse people in health information communication technologies.
In summary, gender and sex are distinct but interconnected concepts. Intersectionality reveals how overlapping identities compound health inequities. Systemic inequities persist in Canada's healthcare system. Inclusive language, gender affirming care, and cultural safety are essential to improving health and access to equity. Digital and simulation technologies in health education can challenge cisnormative assumptions and support transgender health equity. Next steps: 1. Apply intersectional frameworks in clinical education and policy. 2. Promote gender affirming and culturally safe care practices. 3. Advocate for inclusive definitions and research that reflect diverse lived experiences.